Hi everyone, my name is Courtney Rosenthal and I am a clinical nurse and nurse educator in a surgical trauma intensive care unit. And we're going to talk today about the ICU Liberation, or what was formerly known as the A through F bundle. We're going to talk about where these recommendations came from, and we're going to go over the recommendations themselves. So the purpose behind the ICU Liberation is to get patients off ventilators and out of the hospitals faster and healthier. What they found, the Society for Critical Care Medicine convened, pulled several people together from all different disciplines to figure out why patients were having these horrible outcomes, both in the ICU and afterwards. So ventilator-associated events, they were having pressure ulcers, the existence of this post-ICU syndrome. All of those things were making physicians scratch their head and say, what can we do? How can we do better by these patients? This was back when patients were much more heavily sedated on the ventilator, and really the entire treatment of care was so different. So in 2013, the Society for Critical Care Medicine came out with the ICU PAD guidelines, and that was pain, analgesia, depth, and delirium guidelines. So they said, let's see if we can lighten up people's sedation and treat their pain first in order to improve their outcomes. They did this, it went really well, but what they found is that there were still parts of the interdisciplinary team that needed to come together and work to improve patients' outcomes. And that is where the ABCDEF bundle came from. So I'm going to go a little bit over the ABCDEF bundle, or what is now known as the ICU Liberation Bundle. This is what you're going to be responsible for reporting on as the bedside nurse dealing with the patient. So it is mostly intuitive, but we'll talk a little bit about it. So it begins with A, and A means to assess, prevent, and manage pain. The idea behind A is to make sure that we are treating pain before we worry about sedation. Unfortunately, in the past, in order to help patients cooperate with the ventilator and be seeming a little bit more restful in the ICU, we were over-sedating our patients. So what they found, what the research showed, is that we can come down on our sedation when we are appropriately treating pain. That means an entire plan. They do recommend opioid first, but with adjunctive therapies, including non-pharmacologic therapies, and also being really mindful of preventing pain. So proper positioning of the patient, pre-treating before painful procedures. All these things are part of the A part of assess, prevent, and manage pain. B is both spontaneous breathing trials and spontaneous awakening trials. So this is part of our sedation management, but also a huge part of getting our patients off of the ventilator. So a spontaneous awakening trial is when a nurse pauses their sedation in order to allow a patient to awaken as best as they can. How long this takes really depends on the patient, and it depends on the type and level of sedation that they've been on. It has to be done in collaboration with your respiratory therapist if they're the ones who are managing your ventilator, because ideally you're going to wake your patient up and then your respiratory therapist is going to lower the ventilator settings, allowing patients to trigger their own breaths. The idea behind this is to see, is the patient's respiratory effort strong enough to get them off the ventilator? By lowering the sedation, of course, we have to make sure that the agitation is controlled enough to where it's safe to extubate. So that's your B. C is choice of sedation. So you may remember, if you've been around long enough, that historically benzos were had a huge utilization rate in the ICU. Patients were on lorazepam drips or midazolam drips often. That was a standard level of care. That is actually really pushed against in the A through F bundle and in ICU Liberation. Benzos have been shown to really increase the amount of delirium that your patients are experiencing, both in the ICU and afterwards. And they take a really long time to get out of a patient's system. So really making sure that we are evaluating, does a patient need to be sedated to a RASS of -5? Is that appropriate for the patient? As we know in the ICU, sometimes it absolutely is. If your patient's on a high frequency oscillating ventilation and not tolerating it well, maybe they need to have a RASS of -5. But if your patient if we're hoping to extubate that patient in the next day or so, maybe this is a good opportunity to use a propofol or even better, a dexmedetomidine. So that's where your choice of sedation is concerned. D is delirium. That is assessing, preventing, and managing. This has probably been one of the largest shifts in our practice, I think, as ICU nurses, is rather than totally decreasing the stimulation in every single patient's room and letting them look pretty and quiet on the ventilator, we try to keep patients pretty alert, and we try really hard to meaningfully stimulate them. Lights on, blinds open during the daytime, stimulating the patient, letting them watch TV, and having family in the room to stimulate them, really engaging with them during the daytime, and then changing whatever we need to change in order to promote rest at night. We really want to avoid bathing our patients in the middle of the night. We want to minimize lab draws. We want to minimize alarm sounds. Ideally, we're going to keep these patients on a good circadian rhythm in order to prevent delirium, because what we know is that treating delirium is very, very difficult. Once a patient is positive for delirium, it can add days and days to their time in the hospital. So delirium is first line, non-pharmacological, lots of prevention, lots of moving your patient around, stimulating them appropriately. And then secondary, if we have to, then it's about treating and pharmacologically managing a patient with delirium. Of course, we know decreased stimulation is appropriate for some of our patients, including our traumatic brain injury patients. That might be appropriate for a while. But as soon as is appropriate, we need to be pushing them back, getting them back into that daytime, nighttime schedule. E is early mobility and exercise. Again, another huge radical change to our practice. You might be ambulating your patient who's on a ventilator now. There's tons of research about how to properly do things, but the SCCM has recommended the stepwise approach to mobility. That begins with sitting a patient up in bed. If they cannot sit up appropriately in bed, then we can work on doing things to strengthen them from there. But really evaluating how much your patient can mobilize in that bed, and then as is appropriate, getting them out of the bed into a chair, and then eventually to ambulation. What you're going to notice as we finish up this discussion is, I hope in your mind, the idea of, oh, wow, I can't do this alone, because you're exactly right. A huge reason why you're being asked to report on the A through F bundle is to ensure that the proper modalities are being recruited into caring for your patient. So finally, F is family engagement and empowerment. So this is also a huge shift. Many of us may remember the days of the ICU where families could come in for 15-minute increments at a time, once or twice a day, and then they went home. All of the research is steering us away from that. Open visiting hours, open ICUs are where we are going in the future with ICU care. So really ensuring that that family member is at the bedside, it's shown to help reorient the family or the patient member, the patient much earlier, and getting that family member involved in rounds, because the more they know about the care that you're providing, the better prepared they are going to be to, one, hold that story as the patient moves throughout the continuum of care, but also it's going to allow them to provide that continuum all the way home. So getting family involved early, making them a part of rounds, making sure they understand what is said during rounds is a huge part of your job now as a nurse. So again, the things that we want you to know about the A through F bundle are that nobody can completely implement the A through F bundle independently. No nurse is expected to do A through F completely by themselves. If we're doing it right, then what SCCM has recommended is a huge interdisciplinary staff collaborating and building a plan of care early in the day, and then reevaluating that plan of care as the day goes on. The nurse, as always, is the gatekeeper of that care. We hold it all together and we report on it each and every day. I hope that that helps you. Please make sure that you watch or flip through the ICU Liberation PowerPoint that is available to you. The podcast that is linked is phenomenal. It's just a bunch of ICU PAs talking about their experience with the bundle, and I can't wait to watch your example of your ICU Liberation Handoff. Thank you so much, and I look forward to hearing from you.